Good morning, good afternoon, or good evening whenever you are planning to watch this video. Today we are going to talk through therapeutics of type 1 diabetes, which is our next class. So just like before with thyroid, I'm just going to talk through the slides so you'll have something to kind of guide you as you go through. If you have any specific questions once we get to class, just let me know. All right, so before class, all you need to do is review your handout for your RATs and your TBL applications and prepare for your assessments. As with all my classes, I have very detailed assessment objectives, so go through those in your own time. And then I have our TBL application outcomes, so things that we specifically want to do by the end of our TBL application. So again, go through those in your free time. So we're going to start off with just an introduction and review of type 1 diabetes. I know that you guys have had this in your pharmacology or pathophysiology course, but we're going to just review a little bit of the basics and then go on from there. So just to give you an overview, you may already know this, but about 90% of patients actually have type 2 diabetes. So we're dealing with a much smaller cohort of patients that are affected by type 1 diabetes. And typically what happens in diabetes is that it's essentially a metabolic disorder that's characterized by the resistance of action to insulin. So maybe you're making enough insulin, but your body isn't utilizing it the way that it needs to, or insufficient insulin secretion. So maybe you're not making enough insulin, or it could be a combination of both. And what typically happens as the clinical manifestation of that is that you get hyperglycemia or high blood sugar levels. In type 1 diabetes, otherwise known as insulin-dependent diabetes, it used to be called juvenile diabetes just because of when it's usually diagnosed. That is caused by an absolute deficiency of insulin. So these patients don't make any insulin at all, and that's what really differentiates it from type 2 diabetes, whereas in type 2, patients are usually resistant to the insulin that they're making. So their body may be making insulin, but their cells aren't using it the way that they need to, or the cells that produce the insulin have been dysfunctional or aren't working the way that they should be. Some other types of diabetes, other than type 1 and type 2, are gestational diabetes, which can occur just during pregnancy, and oftentimes women will be alleviated of that after the pregnancy. Infections can sometimes cause hyperglycemic states, medications, other endocrinopathies, so other things that are going on within the endocrine system, and then pancreatic destruction. So if your pancreas is not producing or not working the way that it should be, that can also lead to diabetes. All right, so let's go on with type 1 diabetes. As I mentioned, it is autoimmune destruction of the beta cells in the pancreas. So we have these cells in our pancreas called beta cells. There are other cells in the pancreas as well, but the beta cells are specifically what produce or what synthesize insulin. So what happens in diabetes type 1 is that something is attacking these beta cells and they're not able to do their job. They're not able to make insulin the way that they're supposed to. As I mentioned before, it has also been traditionally called juvenile diabetes just because it usually presents in children or adolescents. We usually catch type 1 diabetes early, but we've kind of gotten away from calling it juvenile diabetes just because we have so many more children now that are being diagnosed with type 2 diabetes due to being overweight and things like that. So you can't really refer to it as the juvenile diabetes anymore because we have a lot of juvenile patients with type 2. So going back to the beta cell autoimmunity, it's typically present at the time of diagnosis. And so what happens in these patients is that they have antibody issues. So specifically with the islet cells, islet cell antibodies. So our islet cells are what produce insulin, just like the beta cells. So they're within that same system. So if you have antibodies working against those islet cells, they can't produce the insulin like they're supposed to. We may also have antibodies to glutamic acid decarboxylase, and that is responsible for synthesizing GABA. And you may know GABA as being one of our inhibitory neurotransmitters, but it's also present in beta cells of the pancreas. So it can also be inhibitory in that effect as well. And then also we have antibodies to insulin itself and antibodies to one of our major autoantigens, which is islet protein tyrosine phosphate. And that is also, it plays a big role in secretion of insulin. All right, so here's just a basic view of what our guidelines look like. Just like with many other disease states, there are a ton of guidelines out there that can tell you what to do and guide you through the treatment of diabetes. The main two that we use are going to be our American Diabetes Association, and they usually come out with an update every year. So this is the Diabetes Care 2017. So you guys should look that up for yourselves. You can Google it. You can go to guidelines.gov. And then the other one that we usually look at is the American Association of Clinical Endocrinologists and American College of Endocrinology. And they also produce a guideline that helps as well. For the purposes of our talk today and during class, I'm going to go more with the Diabetes Care Guidelines by ADA. And then I'll have you guys reference the AACE guidelines throughout as I prompt you to do so. But I encourage you to download these files and save them, because we'll be referring to them through our type 1 diabetes discussions and all the way through our type 2 diabetes discussions. All right, so let's start off with diagnosis and screening. So diagnosis of type 1 diabetes is very similar to type 2. You'll see that once we get to that section. But it may be diagnosed based on plasma glucose criteria. So that's one of the first things. So if a patient has a fasting plasma glucose or fasting blood glucose, those words will be used interchangeably, usually greater than 126, then they could be diagnosed with diabetes. Their 2-hour plasma glucose level, especially after a 75-gram oral glucose tolerance test, can be looked at. Their A1C can be looked at, and also their random plasma glucose level can be looked at. Keep in mind that just because they have a 2-hour postprandial glucose of 1, their fasting plasma glucose may not necessarily be the same. So for instance, they may meet criteria for diagnosis based off their 2-hour postprandial, but may not meet diagnosis based off their fasting. Those things are imperfect in their correlation, and as long as they meet one of these criteria, they can be diagnosed as diabetics. Looking at our A1C, you'll get more specifics on this and understand more of this, hopefully, in your biochemistry and pathophysiology course. But the A1C is a laboratory test that provides us with an estimate of long-term blood glucose control. So I usually explain this to my patients as your midterm report card. So you can check your blood sugar every day. Those are like your everyday grades, your RATs for you guys. Your A1C is more like your midterm. So that kind of gives me an average of what your blood sugars have been running over the last 2 to 3 months. So a patient can come in and tell me, oh, my blood sugars have been great. But if their A1C shows otherwise, then that's a big indicator of control or uncontrol of their blood sugar. Some pros of that is that it's more convenient than day-to-day blood sugars, and it has less variability than the day-to-day blood sugars. But a limitation is that it has limited availability and cost. So you're going to have to go into your clinic or your hospital to have this A1C done. There are some home monitors, but those aren't routinely utilized by patients, mainly due to cost and functionality. And then there's also the fructosamine test, which really isn't used very often, but it is one that I just want you to know that it exists. And it's very similar in what it does to as the A1C, except it can detect changes in blood sugar over 2 to 3 weeks versus the 2 to 3 months for the A1C. So if you want an even quicker snapshot of what the blood sugars have been running, you can do a fructosamine test. And again, this is going to require you to come into the clinic or the hospital. And there really aren't any guideline recommended diagnostic use for this at this time, but it is another test that exists. So let's look at interpreting these glucose levels. If you'll see here for normal. So I know we've gone on a few health fairs with some of the P2s and the P1s, and a lot of times patients want to know what their blood sugar should be. So if you have a patient who's not diabetic, that normal range is where they should be. Their fasting blood glucose should be less than 100. Their 2-hour postprandial or post-meal glucose should be less than 140, and their A1C should be less than 5.5. And then if you'll look at the diabetes line or diabetes column, fasting blood glucose greater than or equal to 126, as I mentioned earlier, 2-hour postprandial greater than 200, and that's usually with that oral glucose tolerance test. And then their A1C is usually going to be greater than or equal to 6.5%. So keep that in mind. Those are the diagnostic criteria. And then that middle column, those are things that put patients at risk for diabetes, and I'm not going to repeat those verbatim right now just because we're going to have a whole class on risk factors for diabetes, and we'll talk more specifically about that column at that time. So ADA and AACE actually diagnose diabetes exactly the same. So that that last column on the slide prior to this is exactly what this chart says, just in a little bit different format. So you'll see there are kind of 4 different ways that you can diagnose diabetes. So as I mentioned, fasting plasma glucose greater than or equal to 126. And keep in mind that fasting is defined as no caloric intake for at least 8 hours. So fasting to patients can be different things. So make sure that you are explicit in your explanation of what fasting means for them. So sometimes a patient can say, I haven't eaten and so I'm fasting, but maybe it's been 4 hours or 5 hours. So they need to have had nothing by mouth except water for at least 8 hours. And so usually that's why that level is taken in the morning, because we usually, can go to bed and sleep for about 8 hours and take that fasting level. A second criteria for diagnosis is the 2-hour postprandial greater than or equal to 200. And that's, as I mentioned, during the oral glucose tolerance test. So that test should be described or should be performed as described by the World Health Organization guidelines. And so that's something that you guys, if you're more interested in that and how they do that, you can look that up in your leisure. But just know that patients are essentially given 75 grams of glucose, and then 2 hours later, they are monitored for their blood sugar levels. Because what's supposed to happen is that once your body takes in glucose from whatever source, that could be carbohydrates, a straight sugar source, whatever that may be, within 2 hours, your cells should start to kick in and take that sugar out of your blood and put it into your cells for energy. So if your body's not producing enough insulin to make that process run smoothly, then that can be indicative of diabetes and you still having high blood sugar levels. A1C greater than or equal to 6.5. So again, this is done in the laboratory setting, usually in the clinic. And this is something that should be done in mostly your patients greater than 45 are going to be screened for this routinely. But if you have any symptoms or have any indication that you might have diabetes, family history, things like that, your physician may recommend an A1C. So anytime that level is greater than 6.5, that's indicative of diabetes. And then lastly, if a patient has any symptoms of hyperglycemia at all, and they have a random plasma glucose of greater than or equal to 200, that automatically puts them as a diagnosis of diabetes. And so we'll go through what some of those classic symptoms are in a moment. But any patients that have any of those classic symptoms and they have a little bit elevated glucose level, they're going to be automatically diagnosed. Now, unless the patient has unequivocal hyperglycemia, then these tests should be repeated. So for instance, they may have an okay blood sugar level. Maybe their fasting blood sugar is 120, but they have no symptoms of hyperglycemia. But their A1C is 6.6. So just because their fasting was 120 that day, because their A1C was 6.6, we need to repeat that test, confirm that diagnosis, and go from there. So most of these tests should be done at least twice, unless they have specific symptoms of hyperglycemia. All right, so clinical presentation. Once we get into type 2, again, I'll be able to compare and contrast these a little bit more. But most often, not always, but most often, our patients are going to be diagnosed less than the age of 30 is usually the age that they're diagnosed. Onset is abrupt. So because this is an autoimmune disorder, it's not something that gradually occurs over time. It's something that you're usually born with. And a lot of times it requires some type of outside interaction with something. It could be an allergen or something like that that turns on these antibodies and causes you to have these symptoms, but it is abrupt. It's not something that's gradual. Patients are typically more lean. So, in our type 2 diabetics, they're usually overweight. In type 1, these patients are a lot of times lean, but increased weight is becoming more common in type 1 diabetics. That's probably just from the nature of the American diet and lack of exercise. Increased resistance is absent in these patients. Increased insulin resistance, and that's just because these patients aren't making any insulin at all. Auto antibodies often present. So as I mentioned in the previous slide, a lot of times we'll test these patients for those antibodies against the islet cells, for instance. Symptoms, patients are typically symptomatic. We'll talk about those symptoms in a second. Ketones are usually present, and we'll go into a more deeper discussion on diabetic ketoacidosis and how that occurs and how to check for ketones and things like that. Need for insulin immediately. Every patient with type 1 diabetes is going to need insulin replacement. Acute complications. So diabetic ketoacidosis is the main acute complication of type 1 diabetes. You don't really see a lot of microvascular complications at diagnosis, but you can see some of those macrovascular complications at or before diagnosis, and we'll go through those as well. So clinical presentation, I talked about some of the symptoms that patients may see. So diabetic ketoacidosis is something that can put you in the hospital, and we'll have a whole lecture on that, so we'll talk about that. But polyuria is very common. Essentially, patients are using the restroom very often, frequent urination. Polydipsia, wanting to eat wanting to drink very often. Polyphagia, eating a lot. Always hungry. Weight loss, so patients can lose weight, and that's just the nature of burning off fatty acids and things like that. Your body is using other sources for energy, so you may actually lose weight, and that goes for type 1 and type 2 diabetics. And then lethargy, so patients find themselves tired more so than usual. And in kids, this can be hard to diagnose sometimes because the parents may not always notice that their kid is tired or their kid has lost weight or things like that. So it's something to really look out for, especially if you're seeing pediatric patients, and ask and see if they have any of these symptoms each time. All right, so what are our overall goals of therapy? As pharmacists, we're always focused on what's the goal, what are we trying to do with this particular treatment approach. And so for type 1 diabetics, the main goals are listed here. We want to reduce the risk of microvascular and macrovascular disease complications. So some of those microvascular things can be treated if they're diagnosed early, and usually they should be treated in patients that are near normal glycemia. So once you can get those blood sugar levels near normal, those microvascular complications usually go away. And those are things like retinopathy, neuropathy, things that affect the microvascular system, and we'll talk about those. Macrovascular complications, so those are mainly our cardiovascular risk. And again, we have a whole class on risk factors, but some of those risks can be smoking, so getting our patients to stop smoking, blood pressure control, should they be on aspirin or some other type of antiplatelet therapy, and then treating their hyperlipidemia or dyslipidemia. We want to get rid of the symptoms, so that's one of the main goals. If they're having polyuria, polydipsia, polyphagia, we want those symptoms to be alleviated, reduce mortality, and then also just improve quality of life for patients. So what are our goals? We have a patient who's diagnosed with diabetes. These are the goals based on the ADA guidelines. So for A1C, you're looking for A1C less than 7. For fasting blood glucose, 80 to 130 is our goal. And for postprandial blood glucose, less than 180. So anytime you have a diabetic patient and they want to know what their goals should be, this is what you tell them. These can be variable and very patient specific. Again, these are just guidelines, but for your baseline patient, these are what their goals are going to be. So when they wake up in the morning, they check their blood sugar, 80 to 130 is what it should be. If they have lunch, 2 hours later, blood sugar should be less than 180. And anytime they come in to have their A1C checked, their A1C should be less than 7%. So always keep that in mind. But there can be more stringent or less stringent goals depending on the individual patient. And we do have some patients, especially elderly patients, where we'll target an A1C of less than 7.5 or less than 8, just because they may be at a higher risk of hypoglycemia. I really like this chart because it kind of helps you compare and contrast the different glucose levels to the A1C. So let's look at this. In that first column where you see the red box that I've put around there, the very first column says A1C. The second column says is the mean plasma glucose. So in the red box, you have the milligrams per deciliter of the mean plasma glucose. So if my patient comes in and their A1C is 7, on average, I can assume that their blood sugars at home are about 154, somewhere between 123 and 185, but averaging 154. So that's how you can take the A1C and figure out what their glucose levels may have been running. So if I have a patient who comes in and their A1C is 10, you can see there that they're probably averaging somewhere around 240 milligrams per deciliter as their mean plasma glucose. And as the chart goes on, it goes into fasting, breaks it down into fasting, pre-meal, post-meal, and bedtime glucose levels. So that's something that you can look at if you're wanting to be very specific about a certain patient. But in general, those first two columns kind of tell you just overall what their blood sugars have been running. All right, so let's go into treatment strategies, and we'll talk briefly about some non-pharmacological things, and then we'll go into pharmacological. For type 1 diabetes, it's fairly simple: lifestyle modifications and insulin. Those are the main two things that you have to do. But there can be some little quirky things thrown in there as far as how to manage the insulin. So overall, our treatment approach is going to be to get our blood sugar down, control our blood pressure, and control our blood cholesterol. Monitor for complications that the patients may have. Make any dietary changes that are needed. Patients should maintain healthy weight, get physical activity on the regular, and then also they should have the appropriate medications selected and used. And then lastly, we have to teach every patient how to perform self-monitoring blood glucose. So how to check their blood sugar at home, and then when and where they should go in for their periodic lab assessments. Keep in mind that every patient must include these main 4 things. I think it's 4. So yes, diet, physical activity, medication, and then control of comorbid conditions. So diet, physical activity, medication, control of other conditions, specifically blood pressure and cholesterol. So keep that in mind. So individual evaluation. You want to get a medication history on every patient. Identify the type and duration of diabetes. A lot of times patients will come in and they'll say, I used to be type 2 diabetes, but now I'm a type 2 diabetic, but now I'm a type 1. Well, I'll tell you that that's not how it works. Either you're type 1 or you're type 2. Type 2 diabetics may have gotten to the point where their body no longer makes insulin, but that doesn't make them a type 1. That makes them a progressive type 2. So in the beginning, you need to identify whether or not they have those antibodies, they have that autoimmune issue that characterizes them as being a type 1 diabetic. Characteristics at onset. So are they asymptomatic? Did you find out because they presented to the hospital with DKA, or were they having some mild symptoms that you had checked out? How did you find out that they were diabetic? What's their dietary and weight history? So find out what they're already doing and try to help them improve upon that as they come into this new lifestyle. What's their hospitalization history? So again, have they been hospitalized for DKA or any symptoms that are similar to those of hyperglycemia? Are they having any hypoglycemia? I tell people all the time, a low blood sugar will put you in the hospital much faster than a high blood sugar. So you don't want your patients becoming hypoglycemic, and we'll talk more about that in a second. So if they are becoming hypoglycemic, how often? What's causing them to become hypoglycemic? And is that occurring in the morning, overnight? What time of day is that happening? And is there something that we can do to prevent that from happening? And then you want to get all their labs on initial evaluation. So you want to get their lipid levels, their A1C, how's their liver function, what's going on with their thyroid, get their renal function with their serum creatinine, and then also get electrolyte levels. So starting off with lifestyle management, some of the fundamental aspects of diabetes care are going to be diabetes self-management education, diabetes self-management support, nutrition therapy, physical therapy, smoking cessation counseling, and psychosocial care. And we'll go through each of those individually. But overall, you need to focus on how to optimize their lifestyle at diagnosis. And then at subsequent follow-up visits, you want to assess that and see how they're doing. And then also you want to manage their comorbid conditions. So knowing that, yeah, you treat your diabetes, but you have to treat everything surrounding that contributes to diabetes and that could make that diabetes worse. So starting off with medical nutrition therapy and weight management, DSME and DSMS should always be assessed. So a diagnosis annually, if the patient has any new or complicating factors that come up, and also during transitions of care. So you always want to check in to see how the patient is doing with their self-management strategies. Some of the goals of medical nutrition therapy are to promote healthful eating patterns. So help your patients find things that help them to eat better, address individual needs based on personal and cultural preferences, health literacy and numeracy, access to healthful foods, willingness and ability to make changes, and barriers to change. So there's probably nothing more frustrating to a patient than coming into a visit and having the pharmacist or the nutrition or the physician tell them that they need to change their diet. but not providing any guidance. And a lot of times the issues arise with our underserved populations or indigent populations where they may get groceries at a certain place and they don't feel like they can afford the healthful foods. So it's our jobs to help them come up with strategies that they can use to help incorporate more healthful strategies and more healthful eating patterns. Weight management is also a vital component. It's not as much of a concern as I mentioned earlier. It's not as much of a concern with type 1 diabetics, more with type 2 diabetes, but it is becoming more of a concern in our type 1s as well. Just always keep in mind that there's no one-size-fits-all eating pattern for a diabetic patient. You really have to work with that patient to see what works best for them. A lot of times in an ideal situation, what we'll have is a nutritionist in the clinic or a dietitian. And they can do this medical nutrition therapy. They can counsel, they can give the plate method, everything that the patient needs to make sure that they're getting a good diet. But sometimes that comes on us and that falls on us. And so I know I spend a lot of time with patients in visits helping them find better things to eat, printing out materials for them that talk about healthy weight management and healthy diet. Physical activity recommendations. So overall, the recommendation by the ADA guidelines is that adults engage in 150 minutes or more of moderate to vigorous intensity physical activity per week. So you should do that over about the course of 3 days. They also recommend that you engage in 2 to 3 sessions per week of resistance exercises. So when you're telling that to your patients, of course, tell them 150 minutes per week, however you want to tell them. But there have also been some studies out there that say that they don't have to do a whole 30 or 45 minutes at one time. So if the patient wants to wake up and do a 20-minute walk and then do another 20-minute walk in the evening, some studies have found that that's just as effective as doing the whole 45 minutes in one, big hoorah. So, if you have people that say they don't have time for that, try to come up with ways they can get this activity in a day. And this is more than just casually walking to the mailbox. You have to make sure that you enforce that with the patients and reinforce the idea of moderate to vigorous intensity physical activity. If you have patients that can't tolerate moderate to vigorous intensity, help them where they are and just help them to grow through that. Flexibility and balance training are also recommended. So if patients are up to that, that's something that you can also help them with some yoga, things like that, into their exercise regimen. Smoking cessation, you guys have had that. The effects that smoking can have. So the guidelines are very blunt, and they just say that we advise against the use of cigarette and other tobacco products or e-cigarettes. And smoking cessation counseling should be included in every visit. And other treatment forms can be used as well. So if the patient needs some type of nicotine replacement therapy or bupropion or Chantix or whatever the clinic or hospital offers, it's up to you to help work with that patient and work with that treatment group with the physician and nurses to come up with the best strategy for that patient. But every visit that you see a patient, anytime you have a patient come into your pharmacy and you know that they're a smoker, don't push smoking cessation on them. That sometimes deters patients, but always ask them, do you smoke? Are you looking to quit? If they say no, leave it alone. But it's something that'll keep it on their mind. And most patients actually want to quit smoking. You'll find that. So it's just about helping them become confident in their ability to do so and helping to show them ways that they can do that. And then psychosocial issues. This is one that I do want to spend a little bit of time on just because if you have a patient that's worried about other things or if they have mental health issues, treating their diabetes is going to be one of the last things on their mind. So emotional well-being is an important aspect of management. Psychosocial and social issues can impair an individual's ability to carry out diabetes care. So during your visits, psychosocial screening should be done at diagnosis, at management visits, during hospitalizations, with new onset of complications, and then if you identify any problems with glucose control or quality of life. And you really want to start with informal verbal inquiries. So for instance, I can give you an example from my point of view. When I'm in the clinic, usually I'll ask patients, how are you feeling today? Or has everything been going okay? That just kind of helps them to open up that conversation of, one, I care about what's going on in your day. Two, once the patient becomes comfortable with you, some of that emotional dysfunction may start to come out in the conversations. And if someone's mother just passed away or their dog just passed away, they may not be as in tune to whatever it is that you're talking about during the patient visit. If you're a retail pharmacy, you tend to get to know those patients very well. So if you have a patient that comes in, just ask them, how's everything been going? Just have those conversations, and not only have those conversations, but stay in the know and be very cognizant of if there's any changes. And I can give you an example. I had a student on rotation once, and I was shadowing him as he went in to see a patient that we were both pretty familiar with. He had shadowed me on the visit the week prior, same patient. And so he goes into the visit, and he said, "How are you doing today?" And she was like, "Oh, I'm not doing too well. It's just been a really rough week at my house." And she goes into more detail about how she's having to take care of her mom, and her brother and sister aren't really helping. And then her aunt is really sick, and her aunt lives far away, and she's having to deal with that. And then she's taking her daughter's kids to school. So she had all these lifestyle things going on that are really can affect the way that she treats her diabetes. And so the student went on to say, as soon as the patient finished her story about how she was having a horrible week, the student went on to say, "Okay, so how's your diabetes?" And, so that was a big teaching point for us, because I'm like, today's probably not the day to change things in her diabetes regimen, to address her diabetes as much, because she's dealing with a lot of other things that are going to prevent her and inhibit her ability to carry out her diabetes care. So let's just have a conversation and try to get to the root of some other things as we move forward. So psychosocial issues are a huge, huge, huge deal. So just in general, patient education, don't simply give patients a brief packet of instructions with a few pamphlets. Provide details. Those pamphlets are supposed to reinforce what you teach them. So utilize the teach-back method. Give them very detailed instructions. Write stuff down. Draw pictures if you need to. Whatever you have to do for that patient to help him or her understand. Know that education is important at initial visit and at ongoing intervals. So that can be in the clinic, in the hospital, or in the retail setting. When you have patients come in, if you see that they're on insulin, just make sure that everything's okay with that. See how they're going at regular intervals. Involve the patient in the decision-making process. So if you're looking to change their diet or change their physical activity habits, ask them what they feel they're able to do. Utilize some motivational interviewing and involve the patient in that decision-making process. Emphasize that complications can be prevented. So whether that's hypoglycemia, hyperglycemia, hospitalizations due to diabetic ketoacidosis, emphasize that we can prevent those things and explain to them the strategies of how we can do so. Motivational interviewing has been proven and effective. I mentioned that. And then the American Association of Diabetes Educators has developed the AADE 7 self-care behaviors. And those 7 self-care behaviors are healthy eating, being active, monitoring, taking medications, problem solving, reducing risk, and health coping. And I can show you guys the link, or you can Google that just to kind of see what that looks like. But that's something that's used from a diabetes educator standpoint to give to the patient to help them improve in these 7 domains. All right, so moving on to pharmacological therapy. As I mentioned, insulin is going to be required for all patients with type 1 diabetes. And this is going to be insulin in addition to any non-pharmacological therapy that we recommend. That regimen should be tailored to the patient's lifestyle. And it's typically going to require basal bolus treatment based on self-monitoring blood glucose levels. Basal bolus is multiple daily injections. It can be continuous subcutaneous insulin infusion, or CSII. I used to refer to it as an insulin pump, or it can be twice daily pre-mixed insulin. And that's usually done when the multiple daily injections and the insulin pump are not conducive for that patient. Some contemporary type 1 diabetes management strategies also attempt to match the carbohydrate intake with the glucose lowering process. So we'll talk about how to do carb counting, how to look at an insulin sensitivity factor, and then we'll actually calculate some of those things and change those things once we get into our laboratory session. And then in the future, it's very interesting. They've kind of done some of this here recently, but I think it may or may not become more prevalent in the future. But pancreas transplantation. So they've done some current studies in mice and rats where they take the pancreas from one and put it in the other. The idea is that because the pancreas makes the beta cell or makes the insulin, if we give a patient a new pancreas, then they'll be able to make insulin. The issue that they've come in with that is that because the patient innately has an autoimmune issue, is that are those antibodies then going to just attack the beta cells of that new pancreas? And they've been coming up with some ideas and some strategies to keep the autoimmune cells, or the antibodies, excuse me, from attacking that new pancreas. So something to think about for the future. All right, so looking specifically at insulin, the normal physiological secretion of insulin is really what we aim to mimic with giving patients insulin therapy. So that's why we usually do some type of basal bolus. Basal is going to be that relatively constant level of insulin during fasting and post-absorptive periods. So basal is just kind of that steady state over the course of a day, what's being secreted all day long. Bolus is going to be the spikes of insulin after eating. So once I eat a whole bunch of carbs, my body produces enough insulin to compensate for those carbs. So that's what your bolus insulin is going to be. Insulin sensitivity and secretion are not always constant throughout the day. So while we attempt to mimic this as closely as possible, sometimes your body can produce more bolus in the morning or in less at night, and then the next day it could be opposite. So it's not always very consistent, but what we do with the insulin is try to mimic that as closely as we can, just to make sure that we remain consistent with our insulin levels throughout the day. So as far as insulin regimens, they, as I mentioned, attempt to emulate the normal insulin secretion. So we have our split mixed injections. So basal is going to be the morning dose of intermediate insulin, and that can be MPH, and that's going to provide basal and midday prandial coverage. And bolus is going to be pre-morning and evening meal rapid acting or regular insulin. And if you're looking at a basal bolus regimen, which is the multiple daily injections, basal is going to be given as either an intermediate or a long-acting insulin, and bolus in this case is usually just going to be rapid acting, and we utilize the basal bolus a lot more often. So this chart is very detailed. This is right out of DePiro, but really what I want you guys to do is just get familiar with the medications on this chart. This is pretty much an exhaustive list of the insulin formulations that are available. And so in the first column, you'll see the generic name of the insulin. And then in the last column is the other column that I really want you to pay particular attention to, is the expiration date at room temperature. So you'll see how long that insulin should last, usually once it's opened at room temperature. So insulin is available in several different concentrations. So 100 units per mil, or U100, is the most commonly used. That's what we see with most of our insulins. But some insulin can be available in U200, U300, and U500. And so essentially the amount of insulin per meal increases as you go. So most of the time, U100 is what's used for our diabetic patients. Once you get up to the U200, 300, 500, that's going to be mostly for uncontrolled type 2 diabetics. Type 1 diabetics, because they don't make any insulin at all, they're usually more sensitive to little changes in insulin, and they usually don't need as much insulin as type 2 diabetics. But because type 2 diabetics may not be making as much insulin, and their body may be resistant to the insulin that they're making, you may have to pound them with more and more and more insulin just to get the same effect that a small amount of insulin would have in a normal individual. So 500 units per mil is usually used for those patients who are on very, very high doses of insulin, and we want to concentrate that insulin a little bit more. Historically, when insulin was first found or noticed, it was extracted from beef and pork pancreas. So there were a lot of side effects and things that could go along with that, but now it's all developed in the lab. So we use recombinant DNA technology, and that's pretty much exclusively used in our manufacturing. Eli Lilly and Sanofi use E. coli, a non-pathogenic strain of E. coli, to manufacture their insulins. And then Novo Nordisk uses a form of baker's yeast to synthesize their insulin level or their insulin regimens. So keep in mind that insulin is degraded in the liver by 20 to 50%, but it can also be degraded in the muscle and the kidney. So but mostly in the liver. All right, so pharmacokinetics. This chart I do want you guys to pay particular attention to. So if you look in the first column there, we have the different types of insulin. So our aspart, lispro, glucine, et cetera, et cetera. The main two columns that I focus on as a clinician are onset and duration. So I want to know how fast is this insulin going to start working, and I want to know how long is it going to last in my patient. So we know our rapid-acting insulins, those are the ones that we take right before a meal. Those are going to kick in within 15 to 30 minutes. The Technosphere, that's the inhaled insulin. That one kicks in a little bit sooner. I've never actually seen anybody use that in practice, but it is available if there's somebody that might need to use that. It's very similar to like a nasal type thing. So, and then I want to know how long the insulin is going to last in my patient. So if I give them insulin right now, how long is it going to take before this insulin starts to wear off? A secondary thing that I like to look at is peak. So when am I going to see the peak effect of this insulin taking place in the patient's body? So looking at your short-acting insulin, your regular insulin, it takes about 30 minutes to an hour to start working, and it's going to last for about 4 to 5 hours, or 4 to 6 hours rather. Our MPH is going to kick in about 2 to 4 hours, and it's going to last 8 to 12 hours. And then our long-acting insulins, those take a little bit longer to kick in, so about 2 hours to start working, and then they last anywhere between 14 and 36 hours, depending on which one you're using. So that's why it's our constant level of insulin that we're getting all day. So again, just keep in mind of when the medication starts working and when it's going to start wearing off. This chart right here, this graph rather, I also want you guys to be familiar with, just because it's a very quick depiction of when you should start seeing your insulin working and when you should start seeing the insulin wear off. So it's the exact same thing as the slide before. It just gives it to you in a picture format. So you'll see our rapid acting spikes up really quickly, just like that spike would be after you eat a meal. It's supposed to emulate that. And you have your short acting, which is a little bit slower, immediate acting, a little bit slower, and then long acting, which lasts a little bit longer than the others, and it takes a little bit longer to start working. And then here again, we have the dosage forms, and then the reason why I put this chart in is because it gives you the prices. So insulin is kind of expensive. If patients don't have insurance, it's kind of hard to get access to. So just keep that in mind when you're looking at formularies for patients, recommending insulins for patients, especially looking at those pens and how much those can cost, the pre-filled pens. So you always want to keep in mind the cost and what that's going to cost for your patients. All right, so let's go into initiation of insulin for patients with type 1 diabetes. When you start off, you want to give 50% of that dose as the basal and 50% is the bolus, and you divide that bolus dose between their 3 meals, or they're supposed to have 3 meals a day. If the basal bolus regimen is not near 50-50 mark, you need to reassess the patient's needs and maybe recalculate some things. So for type 1 diabetics, the total daily dose should be 0.5 to 0.6 units per kg per day. Most patients are going to need, on average, somewhere between 0.5 and 1 unit per kg per day, but you start off at that 0.5 or 0.6. Again, 50% is basal, and then some clinicians like to do 20% of the bolus before breakfast, 15% before lunch, and 15% before dinner, but it's not wrong to split that up evenly across the 3 meals. And then you just adjust the bolus percentages based on the patient's eating habits. Looking at the insulin pump or the continuous insulin regimen, I like the insulin pumps for a lot of reasons, but they can be difficult for some patients that don't feel like they want to deal with it. So essentially what they do is they insert a catheter into your abdomen, and that catheter is continuously giving you insulin over the course of a day. It's very sophisticated, and it's much more precise than just injecting insulin throughout the day, because it can be adjusted by the patient or by the clinician, depending on if the patient is at the level where they feel comfortable adjusting the insulin. So you calculate how much a patient needs per hour, and that's how much insulin gets cycled through that machine throughout the day. The thing with this is that it does alert you, but you have to make sure there's always batteries in it. You have to make sure you always put insulin in the reservoir so that it never runs out of insulin. It can also be paired to a continuous glucose monitor. So that's what you see on the left hand side of the patient, or the left side of the belly button is a continuous glucose monitoring system. So the patient is getting insulin through that reservoir on the right side, if you're facing the screen on the right side, and then on the left side, it's monitoring their glucose levels. So that's nice because it can tell you whether or not you're getting too high or too low, and you can adjust the insulin based off that. And you can do that in real time versus having to wait until you have symptoms and stuff like that. It gives you a hypo and a hyperglycemic alert. And insulin pumps are kind of complicated, and usually they're managed by endocrinologists. I worked in an insulin pump clinic during my training where there was an endocrinologist and a pharmacist that kind of tag teamed the monitoring of it. But usually it's going to take someone who's well trained, who's gone through all the training modules in order to really make good adjustments on insulin delivery. The basal rate is, as I mentioned, is going to run continuously over 24 hours, and you can give multiple basal rates if you want to. So you could say from 9 to 10, I want it to be 0.6 units per kg. From 10 to 12, because I know my patient loves snacks during that time, let's increase it to 0.8 units per kg. And then from 12 to 5 p.m., let's go back down to 0.6. And because my patient eats a big dinner, let's do this. So you can have multiple basal rates throughout the day, or you can just do the same 0.6 units per kg all day. It just depends on the patient and what you want to do. Some of the advantages of the insulin pump are that less severe nocturnal hypoglycemia. That's because, again, you're keeping the constant levels. It's more precise. There's not a lot of variability in it. Improved glycemic control and less hypoglycemia overall. Some disadvantages is that it costs a lot. So that's the main barrier to why a lot of people don't get it. Risk of diabetic ketoacidosis, just because if the patient runs out of insulin in their reservoir and they don't realize it, or if they take it off the shower and they forget to put it back on or something like that, they're not getting any insulin at all. Skin issues, skin irritation. They require frequent self-monitoring blood sugars, which that's kind of with every type 1 diabetic, and it requires a lot of patient training. So looking at sliding scale insulin, I'm not a huge fan of sliding scale insulin. It's used more often in the hospital, and sometimes we'll give it to patients at home, the patients that we feel comfortable with adjusting their insulins. But basically, it's a progressive increase in the pre-meal or nighttime insulin dose based upon predefined glucose readings. So essentially, I'm saying if your glucose falls between this and this, give yourself an extra unit or give yourself this much insulin. Part of the reason why I don't like it is because, especially in the hospital, I feel like we're chasing the glucose levels. So if this, then that, versus prophylactically saying, I'm going to give you this much insulin and you need to eat this many carbs based on that. So, and sometimes chasing the glucose can get a little tricky because, again, it takes 30 minutes to an hour sometimes for the regular insulins and things like that to kick in. So what if you check the glucose, an hour later and it's still not where you want it to be? Then you give some more insulin, and then it comes to this thing called insulin stacking, and patients can end up becoming hypoglycemic because all their insulin is piled on and it starts to kick in all at the same time. So sliding scale insulin is not a horrible thing. I'm just not a huge fan of it, especially on the outpatient side or on the inpatient side, excuse me. But if you have patients that can handle it on the outpatient side, I think it's okay. Real quickly, let's go into hospital management. So for patients that are in the hospital, insulin should be started for persistent hyperglycemia starting at a threshold of greater than or equal to 180. And this is different. So patients that are in the hospital, their target range is 140 to 180 milligrams per deciliter. And that's going to be for your patients that are not in the ICU and for your patients that are in the ICU. Same target range, 140 to 180. So that's a little bit different than our outpatients, our general patients, where the goals were fasting 80 to 130, postprandial less than 180. Here, these patients, we want their sugars to be a little bit in the middle, 140 to 180. Sole use of sliding scale insulin is strongly discouraged. So they don't want you chasing the blood sugars in these patients that are critically or even non-critically ill, patients that are hospitalized. They recommend in the guidelines that we use basal bolus plus or basal insulin plus bolus correction insulin. And usually we're going to give IV continuous insulin in our critically ill patients. So instead of poking them, with the syringe and all that throughout the day, we're just going to hang an insulin bag and continuously give our patients insulin throughout the day, similar to what the insulin pump would do. Pharmacist supervision is suggested when transitioning from IV to sub-Q. And so we'll practice that transition once we have a patient with DKA who is hospitalized on insulin. We'll practice how to appropriately convert a patient from IV to sub-Q insulin. But the guidelines do recommend that pharmacists supervise that transition in patients. And usually in the hospital, the protocol is for the pharmacist to do that. And then all patients should be placed on a hypoglycemia protocol. That's just standard. If their blood sugar drops below this, there's a certain amount of glucose that the patient should get. All right, additional management. I'm kind of running out of time, so I'm going to kind of go through some of these things with you guys quickly, but this stuff we are going to reiterate in lab. So if you don't get it right now, we have applications for it in class, and we're going to practice all this stuff in lab. So insulin sensitivity or correction factor. This is the approximate plasma glucose level effect of 1 unit of short-acting insulin in milligrams per deciliter. So you calculate a patient's insulin sensitivity or correction factor depending on what type of insulin they take. So if they're taking regular insulin, you're going to use the rule of 1500. If they're taking rapid-acting insulin, you're going to use the rule of 1800. Some people use the rule of 1700, but for these purposes, we're going to use 1800. And this is very useful in helping to determine how much insulin is required to reach a target blood glucose level. So it's basically telling me how sensitive my body is to insulin. If I'm on rapid-acting insulin and I take 55 units per day, all you have to do is take 1800 divided by 55, and that lets you know how many units of insulin you may need to bring the glucose level, or how many milligrams per deciliter your glucose level will drop with 1 unit of insulin. So let me repeat that. If I'm taking 55 units of insulin per day of rapid-acting insulin, 1800 divided by that 55 units per day is going to tell me how many milligrams per deciliter reduction my glucose will go with 1 more unit of that rapid-acting insulin. And there's some example, the formula is on this page, and we'll do some examples in class. But you always want to check your blood glucose 2 hours after you do that dose. And then the insulin to carbohydrate ratio is a little bit different. So it's not testing my sensitivity level. It's testing, or it's calculating rather, how much insulin I need to cover the amount of carbs that I'm eating. So carb counting is very effective for determining the amount of rapid-acting insulin required for each meal. So a lot of patients will carb count to see, how much more insulin they need to cover the amount of food that they're eating. And so here is the rule of 500. So similar as the insulin sensitivity factor, if my total daily dose of insulin is 76, is what I put in the example here, 500 divided by 76 is going to give me 6.6 or 7 grams. So 1 unit of insulin will cover 7 grams of carbohydrates. So if I'm eating 14 grams in my meal, 14 grams of carbohydrates in my meal, I know that I need 2 units of insulin to cover that meal. All right, and then complications. We may have to talk about this more in class, but here I go through hyperglycemia. Essentially, we talked about hyperglycemia, what those levels mean for diagnosis. This chart right here just kind of tells you how I told you before that not every patient is the same. So your A1C levels may vary depending on your patient. So just kind of look at this chart and identify some of these cases where you may want to be more strict with the A1C or less strict with the A1C for patients who may be at a higher risk of hypoglycemia. Causes of hyperglycemia: eating too much food, obviously, not exercising, or if you used to exercise but you stopped, not taking your insulin, you gained weight, illness, stress, or medications like steroids, thiazide diuretics, niacin, and some of our antipsychotics can cause our blood sugars to spike. And we'll go over a case like that in class. Here, medication-induced hyperglycemia. Sake of time, I'm not going to go through this because we are going to talk about it in class. But one of the big ones I do want to point out is the glucocorticoids. So as the name implies, glucocorticoids, those stimulate glucose production and they block the entry of glucose into muscles and fat tissue. So if you have a patient that's being started on some type of steroid, specifically a glucocorticoid, then they are at risk of having increased hyperglycemia temporarily, or increased blood sugar, temporarily. Hypoglycemia, as I said earlier, this can put you in the hospital faster than a high blood sugar. Patients should always be assessing for low blood sugars. All patients treated with insulin should be counseled on recognition and treatment of hypoglycemia. Assess for hypoglycemia. How often is it happening? How severe is it? Sometimes patients will have a level on their meter that indicates that they're hypoglycemic, but they won't have any symptoms at all. We call that hypoglycemic unawareness, and that can be due to autonomic neuropathy or frequent episodes, and therefore they're just not able to recognize those symptoms anymore. So if you look here on the chart, really just the first line is the main one I want to point out. If your glucose level is less than 70, that's clinically significant, and that clinically indicates that the patient is hypoglycemic. The rule of 15, so this just goes through how to treat a patient with hypoglycemia. It's pretty self-explanatory, so I'm not going to go through that right now for the sake of time. But essentially, you treat with 15 grams of carbs, and then you check your blood sugar 15 minutes later. Microvascular and macrovascular complications. Again, I'm not going to go through this. We'll talk about it in class. But just familiarize yourself with this. Let me know if you have any questions about it. Cardiovascular disease and risk management, very similar to the slide before, same concept. So we'll go through some of these risk management strategies in this class, and then we'll go through it again in our risk management class. Ketosis and testing urine ketones. I do want you guys to really focus on this slide. I'm sorry to not have time to go through it in this video. If you have any questions, let me know, but we're going to talk more extensively about testing the ketones and what that means for patients. How do those ketones present themselves? All of that is here on this slide, but let me know if you have more questions. Sick day management. So this is important for patients if they have the flu or something like that. We recommend that they check their blood sugar much more often. It doesn't occur a lot with type 2 diabetics, but it does occur a lot in patients with type 1 diabetes. So when patients are sick, that can cause stress on their body, that can increase their blood sugar levels. So we recommend that they increase the frequency of how often they're checking their blood sugar throughout the day. Check their urine ketones, especially if they have 2 consecutive blood glucose levels greater than 250, or if they start to vomit and things like that. Recommend that they use short-acting insulin. That way, if they end up giving themselves too much insulin, we know it's going to wear off fairly quickly. Consume 120 to 150 grams of carbs per day. That way we keep a good level of carbohydrates in the body. Continue your current insulin regimen, but then use rapid-acting insulin to supplement that if your levels become too high. And then use sugar and electrolyte, things like sports drinks, to maintain hydration and to help with electrolytes, especially if the patient is vomiting or urinating more often. And then lastly, what are the pharmacist's roles in this? So, of course, we're on this interprofessional team with our physicians, especially endocrinologists, ophthalmologists, primary care physician, and vascular surgeons. Those are the main people that are involved in diabetes care. Dietitians, as I mentioned earlier, podiatrists, especially for type 2 diabetics, but for type 1s too that have gotten to where they have some neuropathy and things like that. Social workers, they help with lifestyle things, psychosocial support, behavioral health. And then pharmacists, the guidelines say, are responsible for providing patient care that ensures optimal medication therapy outcomes. How do we do that? Patient identification, optimizing those medication regimens, medication counseling, so that includes regimen, side effects, signs and symptoms of complications, and other things. What's their initial dose? How do we adjust those doses, and how do we make that best fit the patient's lifestyle? And then monitoring for A1C, liver, renal function, and then referring patients if needed. All right, so that was all I have. The last few slides are what ifs. I do want you guys to answer these, go through them, and see, find out what the answers are. And then if you have any questions about them, we can talk about them in class. And that is it. See you guys in class.